I think we'll go ahead and get started. It is noon and we've got a number of people logged in. So thank you everyone for joining us for today's session. My name is Stacy Grolnick and I'm a member of the Cancer Center Education Work Group. As you join the meeting, your audio will be muted, and we just ask that you remain muted through the presentation. We will have a Q&A session following Dr. Flaig's presentation, and then we encourage you to unmute your audio to ask questions. We can also use the chat to pose your questions, and we will try to get through as many questions as possible in the Q&A. Please take a moment to complete the sign-in by either scanning the QR code that you see on the screen or using the link that has been placed in the chat. This is really helpful to us to measure attendance for our sessions, and then you will also receive a anonymous survey following today's presentation. Please complete this as your feedback is really important and helpful to us in planning future events. So I have the privilege of introducing today's speaker, Dr. Thomas Flaig. As many of you know, Dr. Flaig currently serves as the Vice Chancellor for Research at the CU Anschutz and the CU Denver campuses, and as a longtime member of the Cancer Center, a medical oncologist specializing in the care of patients with genitourinary cancers, especially bladder cancer. Dr. Flaig has served in numerous leadership roles since joining the CU community in 2003, including Associate Dean for Clinical Research, Medical Director of the Cancer Clinical Trials Office, Associate Director of the Clinical Research for the CU Cancer Center. He also serves as a member of the NCI's Investigational Drug Steering Committee in the Bladder Cancer Task Force and chairs the National Comprehensive Care Network, or NCCN, Bladder Cancer Committee. He has served as a PI on a large number of local and national clinical trials over his career, and we are grateful to have such an accomplished clinician and researcher join us for today's session. Look forward to hearing more about bladder and GU cancers and immunotherapy. And thank you, Dr. Flaig, for joining us. And I will turn it over to you to get started.
Well, thanks so much, Stacy. That's really very nice of you. And it's good to see you. You and I go back a ways.
You as well.
Yeah.
We've been here a long time.
We have been here a long time, in a couple of different roles, a couple of ways. So great to see you.
You as well.
Listen, if I say something outrageous or if you want to chime in anytime, you can always unmute yourself to say something too. That's fine. Make this pretty informal. I'm going to share my screen here so you can see the slides. Let's see if I get this to work here. Let's see. Can you see that full screen?
Yes, we can. That's perfect.
Okay. All right. Well, great. So what I've done today is I've tried to combine a couple of talks, actually. One is just more of a general talk about immunotherapy I gave a while back, and it's a nice overview. I know we have a mixed group of people here who have, I would guess, different levels of understanding and exposure to these immunotherapy agents. They've really changed the game in bladder cancer, which, as Stacy mentioned, is one of my special areas of interest, but in other areas as well. So I'll do that. The second part of the talk is really a bladder-specific area. When I first started this thing, bladder cancer was nothing going on. We didn't really have many bladder cancer trials, and there's been a very slow drug development in bladder cancer relative to its importance and its frequency. In all seriousness, no, if I say something that either strikes a chord with you or seems outlandish, or feel free to interject anytime. That's fine with me. I appreciate the feedback. So here we go. For this first part, what the learning objectives are to describe recent advances in the medical treatment of cancer. Just in general, what have we been doing? Sometimes you don't pull back enough to say, what are we doing? What are the tools? What are the basic categories? And understand the modern use of immunotherapy in oncology. And it has changed quite a bit. Again, I do have some experience in renal cell carcinoma where this is relevant as well. So if we were going to take a very broad look, and if we just said, well, let's go to a 30,000 or the 80,000 foot level and really think about oncology. In my simple way, I'd say there's different categories of drugs, the therapeutic agents in medical oncology. There's hormonal agents, cytotoxic chemotherapy, immunotherapies, and I'd say that's old school, and that's what we used to use in renal cell, for example, targeted or biologic therapies, and then modern immunotherapy. Now, I could show you in some of my talks, I'll show prostate cancer, and I'll cite a paper from 1941 from Huggins, in which he talked about hormonal therapy, both surgical castration, but also using hormonal therapies in 1940. So hormonal therapies were arguably one of the first effective systemic therapies we had for cancer. It really goes back, 80 years now. cytotoxic chemotherapies, the age of oncology was started in the 1960s and 70s in a very nascent way, really was started by using cytotoxic chemotherapies, drugs that kill cells, and they have a predilection to kill cancer cells, either due to the rapidity of their cycling or other components that are targeted. But cytotoxic chemotherapy is an approach that started again in that era. It was initially successful in hematologic cancers and germ cells. It has very broad use, which is ongoing. And when I was a fellow, I very distinctly remember the professors in the back of the room. Here I was a fellow in 2003 or 4, wondered what the future of cytotoxic chemotherapy was. I remember talking about it, thinking maybe we wouldn't have to train these fellows too much in that. In the end, it was important to do so. Immunotherapy. So old style immunotherapy in GU where I work, we used to give interferon, for example, interferon alpha, different sorts of things to renal cell. We would give IL-2 in the hospital to renal cell. These are accelerators, or not, I would say, just again, my simple way of thinking about non-specific accelerators of the immune system would turn everything on. And again, these have traditionally been used in cancers that don't respond to chemotherapy. What are those? Those are kidney, melanoma, lung. And again, think of those tumors. Those are detoxifying tumors, sites, or they're areas like the skin that are under constant UV or other attacks. So they're sort of immune to these sort of cytotoxic approaches. Targeted therapy was the next thing. Again, when I was a fellow, these sort of things were coming out. I remember distinctly when EGFR and erlotinib and some of these things came out. This is the idea of using a targeted therapy against a receptor or a ligand or something along that line, so that you have a pathway that's important to a specific cancer and maybe specific to a person with that cancer, then you target that pathway. And HER2/neu and trastuzumab as an example. Breast cancer goes way back. There are now many, many examples, and this is much along the lines of the age of targeted therapy. The thing I'll talk about a little bit more here today, and I'm talking too much in my first slide because I like to talk about this, so I have to keep moving, is really this idea of what are checkpoint inhibitors. Think of the immune system as a vehicle, right? It's got accelerators and it's got brakes. I mentioned in the third bullet there are accelerators, cytokines, interleukins, things that rev up the immune system, right? I think the last time I had a sickness, I had the flu, 4 or 5 years ago. I remember the night before I got a little bit warm, my back itched or something. You get kind of a prodrome when those cytokines start flowing, that something's happening. The immune system also has braking mechanisms, and this is probably a way in which the body controls immunogenicity against itself or autoimmunity. And so you can think of the brakes as being an important part of this whole balance system. Well, checkpoint inhibitors are drugs that essentially are negative feedback. They block the brakes. They're checkpoint inhibitors. And the cancers sometimes recognize ways of using the body's own immune system's checkpoints, their brake systems, to stop the immune system from seeing the cancer, from reacting to it. So again, this is the double negative of us blocking a brake that's being used to stop the immune system from attacking the cancer. And this has really taken off. A couple of quick slides now. So how much development has been done in bladder cancer, just in oncology in general? If you go look back in the 50s, cumulative, these are new medication applications, essentially. You can see there's a steady increase up until about 1990s, and the trajectory of this curve over the next decade went up even faster. And again, that's continued. This is cumulative, but you can see how there's been a steady increase in the number of new molecular entities that we look at here. Here's another way that goes up to the 2010s now. This looks at both small molecules of biologics by decade. And you can see the average annual. So they look at this on an annual basis by decade. Things until the 1980s or 90s are pretty stable. Then from the 1990s on through, there's really been an acceleration of the number of new drugs we have. And so we should just keep in mind that the number of tools we have, the ways you can target pathways in different ways, the classes of drugs we're working with, has really expanded dramatically over the last 3 decades. If we think specifically about immunotherapy and really think about this in terms of the last decade. So if we look back to 2011, 10 years ago, ipilimumab was first really approved for metastatic melanoma. So again, that's one of those cancers I put in that chemo-resistant. Traditional cytotoxic chemotherapies don't work very well. Targeted therapies, immunotherapy do, but the traditional chemotherapy from the 70s and 80s does not. This was the first approved immune checkpoint inhibitor in oncology. Pembrolizumab was approved for melanoma a few years after that, using a slightly different mechanism, but the same idea of breaking the brake. So you disable the brake that's being used by the cancer, so to speak, to stop the immune system from rolling forward. Since that time, many other checkpoint inhibitors have been approved. They're used alone. So again, look at the example of melanoma. chemo-resistant tumors such as that, or in other cancers that have sensitivity to chemotherapy. So think of lung cancer. The checkpoint inhibitors are used in conjunction with other therapies. So we think the key features of these immune checkpoint inhibitors, that new class, really a minority of unselected patients will respond to these checkpoint inhibitors. Now, there's a few melanoma, maybe it's no longer the minority, particularly with double immunotherapy, but for most of these cancers, most settings, it's a minority of patients that are going to get response. The difference is, let's take bladder cancer. If I treat bladder cancer with chemotherapy frontline, the majority of patients are going to respond, right? Unfortunately, those responses are going to be measured in months, 3 to 9 months, sometimes more, sometimes less, but it's a short duration. Oftentimes it's 3 to 6 months. Immunotherapy, the duration of response is long. That's a big difference, meaning that responses can go on for years, even after therapy might have been stopped for some reason. Reliable biomarkers to select these patients have been challenging to develop. There's a number of them out there, mutational burden, PD1 status, and so forth. But we know they're not perfect. We know that patients that are negative to the biomarkers still might respond and so forth. So there's been difficulty in identifying the patients most likely to respond. The side effects of these therapies are distinctly different than chemotherapy, right? So if you've given chemotherapy, so again, I've been giving chemotherapy for 15 or 20 years now, you have a very good sense of what those drugs are going to do. There's a certain pathway. You might say, well, they're having a certain certain group of side effects you expect to see, and patients might have a rare one or a more common one, but you sort of know what that chemical is going to do to the body in large measure. The immunotherapy side effects are really quite different. It's whether or not the immune system starts to have, like, in other words, an immune-related response, an autoimmune response. The immune system is sort of attacking, if you will, in normal parlance, a part of the body, and looking for that. You know, the interesting thing about this, when I prep a patient for immunotherapy, with chemotherapy, you can almost always say you're going to feel bad. I don't know if it's going to be mild or severe, but you're going to have some side effects from this. With these checkpoint inhibitors, some patients have almost no symptoms. Other patients have severe symptoms, sometimes fatal. So it's really a whole different ballgame. And it's been, I think, an important thing for the oncology field to understand these drugs. Move a little quicker through this. There's kind of a couple different classes here. There's PD1, PDL1. Programmed death ligand and the programmed death receptor. That's one of those braking mechanisms. CTLA4 is another braking mechanism. These are the two main things that are targeted clinically. I thought this was an interesting slide. So you see these two bar graphs in each column. The columns show the different drugs, pembrolizumab, nivolumab, durvalumab, and so forth, going left to right. The left column in each of those is the 2017 to 2019. So you can really see, even these couple of years, these are the number of trials that are open. You've got 800 and some trials open with pembrolizumab in 2019. You can see in the colors, I'll show you what they're looking at. Immuno-oncology, targeted therapy, what they're using with chemotherapy and different sorts of things. So there are, literally thousands of trials ongoing with these drugs right now, which is really, I think, a remarkable thing and a lot to keep track of, even in one specific disease. So there's been just a proliferation of this. And I think a lot of us on the cancer trial side of this, we've seen this. We've seen just the multitude of trials that have been opened up, looking at the utilization of these drugs in combination by themselves in different disease settings. We take one of those drugs, pembrolizumab, as you noticed, the most trials ongoing. There's a number of side effects. If you look at the package insert, you can see a number of sort of things. This is a pretty non-specific list, right? Fatigue, musculoskeletal pain, pruritus, or itching, and that goes on in that way. I think what we would notice is that many of these are non-specific and may not specifically be related to the immunotherapy, or they could be. There's this other group of immune-related side effects. So these are things that we believe are really associated with, if not caused by, the immunotherapy. And again, in simple terms, these PD1 or PDL1 inhibitors work to disable that normal immune checkpoint, or a break, in other words. These immune checkpoint inhibitors disable this immune break to overcome this inhibition. So again, if the cancer is utilizing a braking mechanism to stop the immune system from seeing the cancer, so to speak, you need to turn off that braking mechanism. The side effects are related to the immune activation and what part of the body it's hitting in. So you can see this in the skin, the GI tract, and so forth. And the main thing you have to do then is sort of reduce the immune system. So people have these side effects. So a patient came in a while back and their liver function tests were suddenly elevated. They felt a bit of nausea, and they had hepatitis. They had an inflammation of the liver. So I put them on a fairly hefty dose of steroids, prednisone brought down. Some of these patients is more severe, as perhaps the lungs with pneumonitis, either put in the hospital with additional immune reversal type of agents beyond corticosteroids and so forth. So that's the balance you sort of see with these drugs is really quite different. And I think one of the things I've noted here is that treating providers have to be highly vigilant of these side effects. And for those of us that would sort of memorize or have an approach to, given docetaxel so many times now, I sort of know what it can and it won't do, right? This is completely different. It can hit the endocrine system. It could cause a cardiomyopathy, things that are maybe less obvious. I mentioned a few here, adrenal insufficiency. It's a very difficult thing to pick up on. It's a non-specific sort of thing. So it's a whole new world with these drugs, and what they're going to do exactly can be difficult to predict. So again, that's kind of a little bit of a primer on the state of immunotherapy. I intentionally went to a pretty high level thinking about cancer therapeutics, right? We've come a long way, I think, in a period of time, but there are different classes of drugs we use. And so I wanted to make that point. Unless there's any burning questions on that, I'll go through the next part, which is related to talk about bladder cancer specifically.
Dr. Flaig, I just had a quick question about one of the terms you used. You used
Sure.
Braking, what did you use? Braking mechanism. Can you just describe that? I think I know what that means, but would you sort of put that in dummy terms?
No, sure. Yeah. No, I went a little faster. So I think it was Stacy. Thanks for the question. So let me just even take into, sometimes I get the analogy to patients of a car, right? So your car, you got to accelerate your car and you can go faster. And think of the interferons and interleukins. There's drugs that we can give that essentially accelerate non-specific the immune system. And we've done that. In melanoma and renal cell, for example, we've given IL-2 to patients to ramp up their immune system non-specifically, hoping it'll attack the cancer. Sometimes it does in really dramatic ways. The immune system has that capacity, a gas pedal. It's also got brake pedals to slow it down, to reduce its sort of general activity. And so what's happened is that these PD-1 is a way that the body can break itself down, or break or slow down or diminish the immune response at a given time. And the cancers essentially manipulate that natural braking mechanism or downregulation mechanism within the immune system, which it uses to keep itself in balance. So it's attacking an infection or a cancer, but not attacking your body, aka autoimmunity. And so does that kind of make more sense, Stacy, if I say it that way?
Yes, absolutely. Thank you. Appreciate that.
Yeah, and again, the other example I give to patients is, let's say that you have a couple of brakes in your car, right? You have the foot pedal brake, you've got the parking brake, the old-fashioned. If the cancer is sort of locked in your parking brake and your car can't move, in other words, the immune system can't move because it's been blocked by that, and we're not smart enough to fiddle out, we might just go underneath and clip the cable for the parking brake, and that's what these drugs do. Then the car might run a little hot, and you've lost that ability to slow the car down if your other things don't work, and that's what can happen with the side effects, is when that car is running a little too fast, you can't use your auxiliary brake to slow it down. Good question. Anything else on that? And now for something completely different. So we'll shift gears a little bit and talk about bladder cancer. So as I mentioned, I've been interested in bladder cancer for a long time. And if you look from, I don't know, roughly 1980 up until about 5 years ago, there have really been arguably perhaps one intravesicular therapy, and people could argue really almost no new medical systemic therapies in that time. Now, things are being used off-label from lung cancer and so forth, but there was a dearth of drug development in bladder cancer. It's really been, I think, exciting and satisfying for me to see some progress for our patients with bladder cancer in the last 5 to 6 years. It's been very heartening, actually, to see a lot of interest from the drug companies, from the NCI and other groups, to try to improve the outcomes in this cancer, which is not a rare cancer, as I'll point out here. Including a couple of disclosures here. Is this a little bit more academic? We founded a company a number of years ago based on really to help develop some things that we found in the laboratory. I hold a couple of patents through the university. Some of those have been licensed at that company now as well. Stacy mentioned I've been a principal investigator at dozens of trials here at the center over the year, and I've been on a couple of different committees and so forth. So for this part, I thought we could describe the results of recent clinical trials for bladder cancer and their potential impact on treatment. There's been some great work done here. We've played a part in some of this here at CU. Understand recent updates from the FDA about withdrawals and approvals of these immune checkpoint inhibitors, some interesting things there as well. I try to start near the beginning of any of my talks about bladder cancer by saying it's not a rare cancer, it's a common cancer. And here's the 2021 estimates of new cancers in the United States. You can see bladder cancer is the fourth most common cancer in men. And can you see my cursor there? I'm on the right. Stacey, can you see that?
Yes, we can.
Good.
Yep.
So it's the wrong screen, but there's 19,000 cases in females as well. So it's it's not as common in females, which is an interesting conversation unto itself. But this is substantial cancer. There's over 80,000 new cases in the United States every year, fourth most common in men. In terms of mortality, I just make a little plug. Let me go back one slide. So if you think of GU, prostate, urinary cancer, and kidney cancer, really for men, the top six. So in GU, we see a lot of male tumors, and a little bit less so in females for some reasons. Renal pelvis is obviously still in there. If we look at deaths, lung cancer leads there, as we're all, I think, aware of. You can see urinary cancer still in the top 10, urinary bladder cancer there. So it is a substantial cancer. For those of you that know me just a little bit, I like history. I think we have to learn from history. So this goes back to 1975 and looks at the basic incident rates of different cancers over time. So again, prostate cancer, I think I spent a fair amount of time thinking about. If we were sitting here in 1980 or 75, we'd say, lung and prostate cancer are about as common. And then in the 1980s, this dramatic change happened. I know it's kind of hard in the Zoom here. Anybody know what happened here in the late 80s? This is the audience interaction part of today's program. Well, this thing called the PSA sort of rolled into town. It wasn't terribly well tested, I would argue, before that happened, but we essentially doubled the number of patients we identified with PSA. It's fallen the last few years, and that's probably attributed to less PSA screening. Things like lung cancer and colorectal cancer have in a meaningful way come down. Urinary cancer, though, you'll just see remarkably stable over this length of time. And that is, in some ways, a questionable thing. I'll mention later that bladder cancer is associated with smoking, with occupational things. So is lung. And so as lung has come down, this really smoking rates, probably a little bit of screening effect here, but I would say it's primarily from less smoking. If we say bladder cancer is smoking associated, we have not seen that same trend line. But also note that melanoma is going up. I think that's a concern for a lot of us. No major change. Bladder cancer, as I mentioned, fourth most common cancer in men, about 20,000 additional cases in women annually. Over 17,000 deaths from bladder cancer estimated this year. As I just showed you, the incidence of bladder cancer has been very stable for decades. And again, from 1990 to the mid-2000s, arguably really no significant drug development over that length of time for a common cancer. There's a lot of reasons behind that. Just some little factoids for you as you think about this disease. Average age is 73. It's a 3-to-1 male to female sort of thing. 75% of patients are male, linked to smoking. There's a lot of comorbidity because of this. You have an older patient population, oftentimes with a smoking history. Traditional medical approach we've been doing since the 70s really is to give cisplatin as a backbone to systemic therapy. Cisplatin, as I think many of you know, is a difficult drug to give. There's a lot of toxicity to it, requires good kidney function and so forth. Many patients aren't able to receive that. And again, the thing we've noticed is in bladder cancer, because we weren't the marquee cancer getting a lot of attention for drug development, we would look to lung cancer. And almost anything that works in lung cancer would have a shot at working in bladder cancer. We did that. One of the big things we've done in the last few years, last decade, is really the last 6 or 7 years, integrated these checkpoint inhibitors I've been talking about in the first part of the program in the treatment of bladder cancer. I didn't put a 1940s paper in my talk this time. To be a little bit more updated, I put a 1970s paper in. So this is, so you can see it's hard to get a good copy of this from the 70s. This is 1976, intracavitary BCG in the treatment of superficial bladder tumors. Again, I think it's hard for everybody to chime in, but BCG, anybody know what BCG is used for? It's a TB vaccine, primarily used in Europe and other parts of the world. So why in the world were they putting a TB vaccine into the bladders of men in the 1970s? And the answer is, I asked one of the authors of one of these early papers, not this one, but someone else who has published a paper just the year after this. The response was it works so well in melanoma. It doesn't really work that well in melanoma. I guess the point is they didn't have much to work with in the 1970s. So they took something. Now, this it does cause some immune stimulation, to be sure. Actually, it irritates the bladder. This is a study, I think, with 9 patients, but BCG has remained a backbone of therapy into the current era. In fact, there's issues with shortages of it. So we continue to use this to treat bladder cancer. It does give you an early look, though, that again, you argue this is one of the earliest modern experiences using immunotherapy in cancer. This is it. And it shows you that there's an immune footprint in bladder cancer where there could be some responsiveness to these sort of things. So as I mentioned, what works in lung cancer oftentimes works in bladder cancer. Bladder cancer is largely driven by environmental exposures, not completely, but there's certainly a connection to smoking, many other occupational hazards, everything from people who work in certain industries or exposed to certain chemicals. And if you think of the drugs that work in lung cancer, platinum-based drugs, gemcitabine, taxanes, immunotherapy, they almost all work in bladder cancer as well. Here's a famous plot for some people that follow this field. This is published in Nature. It's almost 8-9 years ago now. This goes from left to right, the somatic mutation frequency. So you essentially take a tumor and say, what's the amount of tumor the amount of mutation that this tumor has, and how does that vary between types? So you can see for some of these childhood cancers, there's actually a very low burden of mutation. Mutational burden is low there. You take these on the right side, bladder, lung, and melanoma, these had the highest mutational burden. And lo and behold, these, I would argue, that are the cancers in which these immunotherapies work the best. You can get into this thing about neoantigens and looking at really targets and stimulation, but bladder cancer, again, does fit with lung in that kind of category. Give a couple of case studies of different drugs. Now, some of the best data in bladder cancer, really one of the only randomized data set, we've got a couple now, but one of the few randomized data set we have in this is pembrolizumab as second-line therapy. So this is a PD-L1 oriented drug. It's used in a phase 3 randomized study. It's not a huge study. So for a phase 3, it's got 542 patients. It was randomized between pembrolizumab and dealer's choice of chemotherapy. These are patients with advanced urothelial cancer who progressed after platinum-based chemotherapy, looking at overall survival, progression-free survival. And pembrolizumab is a PD-1 inhibitor. As I mentioned, that's essentially releasing the brake, right? You've essentially allowed the immune system to roll forward. You can see the top part here, the overall survival. There's about a 25% reduction in the risk of death. The red line is ahead and above the blue line. So it shows you the difference in effect here with the pembrolizumab versus the chemotherapy. The progression-free survival, again, just to orient you these, if the line goes completely across like this, you'll see that means that everybody, for example, is still living or hasn't had the event you're looking at. As these lines fall down, you'll see the separation here. And the red line is clearly above the blue line. Here you look at progression-free survival. And so the thing you find here is that 18 months, for example, 20% of the patients have not progressed. And that's interesting, whereas really all the patients in chemotherapy have progressed at that time point. So here it just talks about that durable response. If we follow this out over time, there's a group of patients, it's a minority in this case, that do well over a long period of time. These are called swimmer plots. So these essentially show individual patients that have response. This is a pattern. The overall response rate is 21% with pembrolizumab versus 11%, right? So your response rate is higher than we saw with chemotherapy. Now, the thing I'll note, this shows month 0, 3, 6, 9, right? Patients going on. The little X's recognize when patients have had disease progression or death, unfortunately. The green arrows represent an ongoing study treatment response. You can see the red area of pembrolizumab, there's more patients with response, almost roughly twice as many. If you look on the right, it might be hard for you to see, but the vast majority, perhaps the vast majority, still those green arrows. The drug's still working. We see less responses to chemotherapy. We see shorter responses. We just see maybe a couple of these in the middle that still have an ongoing response. So the vast majority are not durable, and they only last a number of months here. It's rare to see these responses much beyond 9 months, as I mentioned before. That's a big difference. I think we'll make that point. Again, while only 20% of patients respond to this cohort, those that did respond tend to have prolonged, durable responses with these immune checkpoint inhibitors. One interesting sort of thing is that at one point, I could give a talk and say that there were at that point 5 checkpoint inhibitors that were available, FDA approved, and they were all approved for bladder cancer. And I think lung had 4 of the 5 at one point, and so forth. So bladder cancer went from this drug with no development, this disease with no development for years and years and years, and then suddenly having these 5 drugs. Now, There's a few that I've kind of grayed in here a little bit, atezolizumab and durvalumab. Those have been pulled back recently, which is interesting. I would say, again, this is just sort of a pedestrian view of it, or explanation of it, but there was such excitement to have some drugs with activity. These were approved in early data. And then in the end, when more data came in, you can see I put in some of the press releases about this. There's a voluntary withdrawal of these drugs by the company, a couple of them. So again, as we think of ourselves as in the drug developing area, clinical trials, these were early trials, single arm trials. There was clear activity, they were approved, but as more data came in and so forth, both safety and efficacy, those preliminary approvals, provisional approvals were taken back. All right, we'll shift gears again then. So I think first of all, we talked about just some general oncology things. We talked about the general field of immune checkpoint inhibitors, put that in the context. I've given you some background of bladder cancer, something that's near and dear to my heart because it was a neglected cancer for a long time, and now there's some activity there. And then I've most recently showed you some of the data for immune checkpoint inhibitors in bladder cancer. And I'm going to try something pretty different. And this is work we've done now really through our group and the GU Oncology group here in Colorado and my partners in the clinic and so forth. I'm going to give you just a little bit of setup for this. So, one class of drugs I didn't mention, what I talked about in the first one, I talked about hormonal therapies, I talked about older immunotherapy, I talked about cytokines, target therapies, and then newer immunotherapies. So those 5 classes, I just sort of said, take this 80,000 foot view, right? We'll be in early space where we're looking at a high level. This is maybe some people would argue this is a 6th category. These are antibody drug conjugates. So these are essentially 2-part drugs. One part is usually a targeting antibody against a specific target. In this case, is Nectin-4. Nectin-4 is found highly expressed in bladder cancer and some few other cancers, but it's not expressed in any normal tissue, except the skin does have some, and a few other places have minor expression. So you've got this antibody that'll direct, and then you've got a payload of drug. And what they tend to pick for a payload is a very, very potent drug. So it's just a small number of molecules that have to be associated to kill the cell. And so essentially the antibody is floating, given systemically, it floats to the body, it finds its target, Nectin-4 in this case, it's on the tumor and not anywhere else. It gloms on there, it's internalized, it releases that payload in the cell and it kills the cell. And so it's different than targeted therapy. Again, I mentioned trastuzumab or olatinib, these drugs that target a pathway, and that was a significant breakthrough. If your cancer is dependent on that pathway and you block it, you have a response. These use physical targeting. The cells don't have to be reliant on a growth pathway of Nectin-4 or these other things that are targeted, but they have to have differential expression of that particular target. Those are called antibody drug conjugates. The antibody is the directing, the drug conjugate, the drug is the payload of highly potent drug. It's a new class of drugs. You see it developed now in breast cancer, certainly bladder cancer has got a couple of approvals now. This is a drug that we were involved with. And this was a phase 1 study, EV-101. EV is for enfortumab vedotin. And again, our center here played a significant role in this. Phase 1 study. Now, phase 1 studies have gotten larger over the years. I'm not a traditional phase 1 person, but we do some of these disease-specific trials. This was 155 heavily pretreated metastatic urothelial patients. Progression after one or more chemotherapy regimens. And again, 29% had 3 or more lines of chemotherapy and/or immune checkpoint inhibitors. And from this, we determined the phase 2 recommended dose of 1.25 milligrams per kilogram. And in this, we found of the urothelial cancer patients got adequate dosing, the overall response was 43%. Now, remember back to that first study I showed you from the New England Journal of Medicine. Remember, the chemotherapy response was 11%. For years, we sort of estimated that to be 10%. So I think that's pretty close to what we're seeing. So again, for this phase 1 study, we saw a disease population where we saw response rates are perhaps in the 10% range. It's always hard to compare, but maybe let's say it's a 10% range. And that was oftentimes second line. This is now second, third, fourth line patients clearly would have a lower response rate, I would argue. And even at 10%, we saw a 43% response rate in this phase 1. And the overall survival at 1 year was 51.8%. So this is a pretty exciting study. And here's a waterfall plot. Each individual column is an individual patient here. You can see it's color coded. The red is the PD-L1 therapeutic naive, and the blue is those that have had previous PD-L1 inhibitors. So you can see there's not a rhyme or reason to that. The PD-L1 treatment status did not have a significant player. The little asterisks, which you see scattered around here, show those that have visceral metastases or liver metastases specifically. And you can see more of those over on the left side. So again, just to orient you, if you see these lines going up here, you'll note that that those patients just had progression, but all these patients over on the right side have had a reduction. You can notice the ones over here, they've had really 100% decrease in the size of their tumor. Those are complete responders. And all these little asterisks are visceral metastases. Now, we've always, liver metastases specifically. We've always had much more difficulty with liver metastases. Those patients have very poor prognosis. But you can see some of these patients over here with responses have liver metastases at baseline. This is interesting as well. So this is another one of those swimmer plots, right? So you can see that a lot of these have the green kind of arrow of ongoing response. A number have no ongoing response, but you would see that some of these have some durability to them as well. So you're seeing responses in late stage patients, some of which seem to be hanging on there, which is exciting. You know, in some ways, I sort of started this by saying, is this a new class of drugs? You could argue antibody-drug conjugates is a class of new, but they're really delivering chemotherapy. And in some ways, you can think of them as chemotherapy agents. In this case, the two more substantial side effects I just point out are neuropathy, that's related likely chemotherapy agent, the macular papular rash. And the other thing I noticed is that the Nectin-4 is shown, it does display on in the skin. So here's some skin toxicity from that. Here's a second paper I'll just show for completeness. We did not have a role in this paper. It's a phase 3 study. So based on that early work was done, a phase 3 was done, it was randomized study. This looked at patients that had passed platinum, meaning cisplatin, carboplatin, they had immune checkpoint inhibitor. 608 patients, again, a pretty modest size phase 3 study, randomized to 40-mAb vedotin if the dose was established in the phase 1 versus investigator selection, dealer's choice of chemotherapy. Again, here's the plot. The more separation you get between these two lines, the better. In 40-mAb vedotin has nice separation. The hazard ratio here shows about a 30% improvement overall survival. The p-value is highly significant with this. And so this is randomized head-to-head data, really establishing a role for this therapy and other therapy. And this is true both progression-free survival shown here and overall survival on the previous slide. Now, here's one other thing I'll just say. Now, this is EV study 103. So we've had a number of these studies open here. And again, this is another one that our group here, and I don't know if any of our coordinators are on, they've done a great job with this. Mike and the team there, and Kirsty and everybody else for a long time, and my colleagues in clinic. This is looking now at taking in 40-mAb vedotin plus pembrolizumab. So we're doing is taking one of those antibody-drug conjugates we've been talking about the last little bit here, adding in pembrolizumab, one of those immune checkpoint inhibitors. This is a combination approach to this. And the design was basically a dose escalation with just a few patients in 40-mAb vedotin plus pembrolizumab. These patients were all cisplatin ineligible, so that backbone therapy I mentioned they weren't able to get, and then a dose expansion of this. And again, locally advanced or metastatic urothelial patient, cisplatin ineligible, just 45 patients. Dosing was given in 40-mAb vedotin on days 1 and 3, and this went on for some length of time then. So just share this waterfall plot. Now this does look different than what I showed you a little bit ago. Again, there's fewer patients in the previous one. I just go back for a second. So sort of leave this one in your mind, right? We'll go to this one. First, we see that you have a very high response rate here, 73%. That's notable. You really have very few patients that have any kind of growth. There's a few here. 93% had a tumor reduction in this. I mentioned there were some biomarkers that we used for the PD-L1 inhibitors like pembrolizumab. We show that here. And again, that's pretty randomly distributed here. It doesn't look like it's all on one end. So that may not be helpful here. A number of patients here, about a half dozen that have complete responses to this. Responses were observed regardless of the PD-L1 status. This is pretty exciting paper in that regard. Here's a spider plot. So the one thing I'd say here is there's a few patients that are not responding. That's the gray on the top. Again, this is now 43 patients, a few we couldn't analyze. These yellow arrows are ongoing. So remember I said the key differentiator of the pembrolizumab type drugs was durability. I can give chemotherapy to bladder cancer patients and see the majority of them respond And of course, the majority of them relapse within the first year, the vast majority in the first 6 to 9 months. Here you see this durability. So now is there a possibility that you have these higher response rates with the durability that we've always sort of wanted? And this is an early study, but I just want to share this one with you of where the field is sort of going here. It's pretty exciting. And this just gives some more data. The overall survival is again, single arm studies. So have to be a little bit careful. We don't have a comparison arm built into this, but this is, as we say in oncology, sometimes pretty encouraging. You look at the side effects of this, I guess the question would be, do we see more immune mediated side effects from this sort of approach? The sensory neuropathy, which you see for the EV and for vedotin is there, the rash is there. You can see over here, there's really doesn't seem to be a strong different side effect profile in a small study with a small number of patients comparing these two things here. I'm just going to make a few more comments about one more therapy. I'll wrap my thing. I've just got a few slides left here. So we've talked now about checkpoint inhibitors being 5 approved for bladder cancer, now 3 are in use. We've talked about EV and 40 vedotin. This is an antibody drug conjugate being used here, kind of a new therapy targeting antibody with a payload of drug. And this is more of a targeted therapy. So again, in this case, we're looking at an FGFR 1 through 4 inhibitor, kind of a pan inhibitor. This is a small study now, just enrolled 99 patients. It did end up in this obscure journal called the New England Journal of Medicine, which means it's important to see that. And this was really given to select patients. So a small study in those patients that had pre-specified FGFR alterations. So this is a specific receptor pathway mutation in which we think that blocking that with this targeted agent is going to make a difference. And so a similar plot here, looking at the responses. So you see responses in a large number of patients here. The blue indicates ongoing treatment again. So this is a more complex plot, but you can see a good number of responses there. And I think I put this first slide here, confirmed response rate was 40%. So really quite a remarkable response rate when you think that our baseline, our sort of historic response rate in the second and later line is about 10%. So these are significant improvements. Again, you see some side effects here. These are more in line with the side effects you expect with the tyrosine kinase inhibitors, stomatitis or mouth sores. It just the hypophosphatemia is seen, a low phosphorus level, and so forth. Well, I got through my slides relatively quickly. I have a little bit of time left for questions if we have some. So there's a lot of important questions that remain in bladder cancer and immunotherapy. I hope this was a helpful, if not a whirlwind, tour of sort of the space. We have ongoing trials looking at a lot of different things in urothelium, so it's really exciting to me. At some point, there was just sort of a threshold by which we could say, listen, we can get trials done in bladder cancer. If there's drugs that make sense here, we can accomplish these trials. We convinced, I think, the federal authorities at the NCI as well as drug companies that being the case. There's now a combination of different sort of checkpoint inhibitors, a la melanoma. There's checkpoint inhibitors plus chemotherapy. I mentioned checkpoint inhibitors plus the antibody drug conjugates. There's the neoadjuvant therapy. There's the perioperative, let's say, application of these drugs as well. There really is a need for better biomarkers, though, I think, to be sure. So that's one area where we have a significant need. And I think using genetic subtypes might be another way forward. So in summary, the landscape of bladder cancer has changed very rapidly in the last several years. If I was giving this talk 10 years ago, first of all, I wouldn't ask me to give the talk because there wouldn't be much to talk about. I would say a bit about cisplatin and different ways of sort of rearranging the chairs there. We spent our time trying to do some mild dose modification or dose densification, but there wasn't much we were doing. 5 PD-L1, PD-1 inhibitors have now been approved. There's actually 3 that continue to be in use. There's a couple of those were withdrawn, but they've really changed, I think, the way we look at and treat bladder cancer. In 40 vedotin, erdafitinib, that last drug I just showed you, represent newer lines of therapy. And the ways that we can combine and integrate those drugs, which will take new trials, is really pretty exciting. And I think biomarker development to select patients for these therapies will be an important next step as well. So, okay, well, Stacy, I didn't run over, that's for sure. So I'm going to stop sharing here and leave things there. There's Cynthia as well. Hi, Cynthia. How are you?
Hi, I'm doing well. How are you?
Oh, well.
That was
time for questions if there are something.
Yes, I have 2 questions that have come in on the chat. And the first one is from Ann Martin. Why does bladder cancer affect so many more males than females?
And it's good to hear from you. Thanks for the question. If you'd asked me that 10 years ago, I would have said something along the lines of, we think bladder cancer is highly, or at least moderately associated with smoking. There's more smoking in men. And there's also some overlay of occupational exposure. Certain kind of industries, factory industries, which are traditionally more male oriented, also had some risk. But I would have said occupational exposure and smoking, which are different in men than women. That's the difference. And it's probably still the party line if you ask people. But I showed you that line, right? It is dead flat. And so there's less thinking of the impact. The last 30 years hasn't changed. I think there's some biologic to it we don't completely have understood. Dan Theodorescu, who's a cancer director prior to Dr. Schulich, actually published one paper on this, said that there's interaction with the androgen receptor and bladder cancer. It's very interesting. Obviously, the androgen receptor would be different in men and women. So I would say the traditional explanation does not satisfy the current condition. I think there's likely something biologic, and it'll likely be solved through some laboratory work, maybe related to the androgen receptor, interestingly.
Okay. Thanks, Dr. Flaig. We have one other question that came in on the chat from Stacy. She may have to hop off a little early, so I'll ask this. With the high incidence of bladder cancer, are there known screening activities or preventative behaviors that are recommended?
It's a good question. There's no distinct screening paradigm for bladder cancer. So you think of PSA for prostate cancer, or mammography for breast cancer, so colonoscopy for colon cancer. We don't have something like that for bladder cancer. Usually what will happen is a patient present with hematuria, some gross blood in the urine, and then they'll undergo cystoscopy. So a small catheter will be placed, or a scope will be placed in the bladder. You look for bladder tumors. That's been the sort of traditional approach to that. Now, I'll tell you, again, we talked about the predominance of men with this disease. I have treated a number of women with the disease that have more advanced disease at presentation. Part of that is a delay in diagnosis, so that perhaps blood in the urine isn't taken the same way, or there's some other explanation given or something. So I think it's very important that people have gross hematuria, they have a proper workup for that. The other thing I'll mention is that you'd have to look at the upper tract. So you think of the bladder here, the ureters going up, and then the kidneys, the urothelium. So that lining that becomes, so bladder cancer is lined with the urothelium, but so are the ureters, the lower part of the kidneys, the renal pelvis. So the other thing you have to do is if someone presents with blood, you look in the bladder typically, or you think about doing that relatively early on. And then you have to look up into the upper parts of look up the ureters and the lower parts of the kidneys. And so you have upper tract disease. It's not something I talked about, but it's urothelium. It's urothelial carcinoma. We treat it in a similar fashion, but that's something else I would sort of mention along those lines. So it's not a distinct screening, but you have to be aware of hematuria for sure.
Okay. Are there any other questions? Please just unmute yourself and speak up.
Hi, Dr. Flaig. It's Jake from the research team.
Hey, Jake.
I was curious, do you think cystoscopies will become routine for screening, like similar to colonoscopy for colon cancer, or do you really rely on more reporting of gross hematuria and then do the exploration?
Hey, great question, Jake. It goes back to what I said before. This was a neglected cancer, and I mean, I'll say this probably as a friendly audience here. Some people start discouraging me from focusing kind of an academic career in bladder initially. So I do a little bit of lab work, and so we had developed some models and things, different cell lines, and so forth, trying to understand bladder cancer better. And people say, well, nothing ever happens in bladder cancer, so don't do that. You won't be able to do anything academically. And so I was stubborn enough, I sort of stuck with it. But there just hasn't been a lot of thought on these things and how to maximize the care of bladder cancer patients. It seems to me, Jake, that probably the cystoscopy is it's too invasive and probably too expensive to do on a real broad scale. And what people might do, though, what happens is if you have, let's say you have a bladder tumor and either it causes you to bleed and you see that, but you're probably shedding something in the urine that we could detect. So if we had a really good urine-based study and there was something specific, maybe it's Nectin-4, something like that, a marker that's seen in bladder tumors, but not the normal bladder cells that are shed into the urine as well. It would seem to me there's some kind of screening test there. There's a few people that have been working on these sorts of things for people. Once they have blood in the urine, they'll do some of these urine-based assays, but maybe there's something broader that could be done in that regard. And again, just as you kind of see, there's always been this dream that we could test people's blood and have a sense if they have a cancer and what kind it is and do early detection that way. That's actually becoming something we could even imagine happening as we get better with the sensitivity of our detection and the specificity of our targets. But I would suspect if we get into a screening, it'll be something along the lines of a urine-based screening. All of what we do now for people that have blood in the urine sometimes. Good question, Jake. I appreciate that.
Yeah, and then just one more follow-up question for you. Do you see the direction of, advanced muscle-invasive bladder cancer progressing more towards the PD/PD-L1 inhibitors with something like EV? Do you think that'll become more of the standard regimen to combine those two?
Yeah, another great question, Jake. And so I skipped over a little bit for people, but you got kind of three states of bladder cancer. There's non-muscle invasive disease. There's superficial tumors. They can be scraped out. They're not a mortal threat, but they need to be observed. There's muscle invasive disease where they grow into the muscle of the bladder. Think bladder is a muscular ball, right? So it grows into the muscle. The muscle serves as the protective barrier. That then becomes a threat to the patient's mortality. And metastatic disease, where I spend most of my time. Jake, I think what will happen is a lot of the drugs systemically that work for systemic disease, metastatic disease, will try to be applied and are being applied to this kind of muscle invasive and earlier disease. What it's going to be, though, is a balance between the safety and efficacy and the risk of the cancer. So again, I think a legitimate discussion, because there is now some use of pembrolizumab, for example, in earlier stage disease, but what's the risk of the drug versus the risk of the disease, and when does that balance become appropriate? So it'll be along those lines. But what we always do in oncology, we establish a drug in sort of far advanced disease, metastatic disease in a phase 1 heavily pre-treated population. Once we show activity, we try to march it up to the place where it makes the most sense, the disease course. And again, the GU team has seen some of that stuff happen. We've taken these from these very late stage patients that don't really have many other options, showed good activity there and brought it up to an earlier stage. So I think there'll be a lot of application of these drugs and plenty for the team to do, Jake, looking at these in an earlier setting.
Yeah, excited to see the work that comes out. Thank you so much for this presentation, Dr. Flaig.
Yeah, thanks for your question.
Anyone else with a question?
Well, stunned silence, I guess, Cynthia. What do you think?
Well, it was a very thorough and really interesting. As you, I used to work with you a long time ago. I kind of knew that was PSA came in that.
Could have guessed that one. You probably knew that one, huh?
Yeah, I was sitting here thinking, I think it's the PSA, but
it's hard these
anyway.
video things, isn't it? In the room, it's I can hold my talking about 10 or 15 seconds in a room with people, but it's harder for me to wait longer on the videos. You have to.
Yeah, well, thank you so much for this great presentation, and it is being taped and it'll be available a little bit later, and we'll let everyone know about it. So if there aren't any other questions, we will close this out.
I just say, listen, I think so. This is a lot of the Cancer Center team members. I recognize a lot of names here, not all of them, Cynthia, though. This is coordinators from across the Cancer Center.
Yeah.
Yeah, and other people. Well, listen, I just say thanks to all the coordinators and the whole team for what they're doing. I think if you look at, I try to show this in terms of trials. All this is about trials, right? It's successfully completed trials, gathering right safety data from all those AEs that we collect, understanding how these drugs work, what the side effects are, and so forth. So it's all on the basis of the trials. Nothing happens without successfully completed trials. So thanks for what everybody does here to make those things happen.
Well, thank you for all you do, and we really appreciate it.
All right. Well, have a good day.
Thank you.
Bye.
Hi, everyone.